Hello, my name is Ying Qi. I'm a doctor in Department of Radiology at Shengjing Hospital of China Medical University. Thank you for giving me this opportunity to share my experience. Today, I would like to say something about the imaging diagnosis of common diseases. We will focus on three sections, including nervous system disease, skeletal system disease on brain tumor, and digestive system disease on liver. What I'm going to talk about part 1 is the cerebrovascular disease and brain tumor. Stroke is a disease that affects the arteries leading to and within the brain. It's the number one cause of death and the leading cause of disability in the United States. It's the number one cause of death in China. There are various types of stroke, mainly containing ischemic stroke, hemorrhagic stroke, and transient ischemic attack, TIA for short, also called a mini stroke. Just as strokes have many effects, they also have many causes. Ischemic stroke occurs when a blood vessel supplied blood to the brain is obstructed. It accounts for 85% of all strokes. Hemorrhagic strokes occurs when a weakened blood vessel ruptures. The two types of weakened blood vessels are aneurysm and AVMs. The most common cause of hemorrhagic strokes is uncontrolled high blood pressure. TIA, called a mini stroke, is caused by a serious temporary clot, is a warning stroke and should be taken seriously. Ischemic strokes are often classified by the vascular distribution involved. Anterior circulation strokes involving the areas served by the carotid catheters ACA and MCA represent over two-thirds of all ischemic strokes. 96% involve the middle cerebral arteries distribution. 3% involve the cerebral artery distribution. 1% involve the internal carotid distribution. Posterior circulation strokes, on the other hand, involve regions supplied by the vertebral arteries and represent 25% of all strokes. The vascular distribution involved will determine the clinical features of the stroke and often produce typical stroke symptoms. Acute ischemic stroke is a clinical issue. Time is the most important in diagnosis and treatment. Imaging diagnosis plays a decisive role. CT is the first choice in acute stroke. The purpose is in order to exclude hemorrhage and underlying mass or AVMs. Ischemic stroke usually have 4 stages. Today, in patients with acute ischemic stroke, standard protocol includes non-contrast CT scan, contrast CT scan, CT angiography, perfusion CT, magnetic resonance imaging (MRI for short), and diffusion-weighted imaging (DWI for short). If time less than 6 hours, called super-acute stage. 40% of CT and MRI have normal imaging. However, DWI shows high signal intensity lesions. From 6 to 72 hours in acute stage, CT shows low intensity, mass effect, redshift and special CT signs. From 4 to 10 days in subacute stage, gyro contrast enhancement due to green-white matter edema. If time more than 11 days in chronic stage, CT and MRI could show focal tissue loss, such as atrophy, cavitation, focal ventricular dilatation. Look at this case. We can see the redshift and hypodensity in the right frontal lobe on CT. The blood supply here is anterior cerebral arteries. Look at the case of MCA ischemia. We can see the wedge shape and hypodensity in the right frontal and temporal lobe on CT. The blood supply here is the middle cerebral arteries. The middle line little shift. The right ventricle is compressed. Now we can see the picture shows PCA ischemia. We can see wedge-shaped and hypodensity in the right occipital lobe on CT. The blood supply here is the posterior cerebral arteries. The right ventricle is compressed. We can see special CT signs in early MCA ischemia. The special CT signs contains insular rainbow sign. The right insular boundary is fuzzy. The left insular boundary is clear. Another CT sign is lentiform nuclear edema sign. CT shows the right lentiform nuclear hypodensity. Its boundary is fuzzy. The right MCA shows hyperdensity, which is a special CT sign in early MCA ischemia. This picture gives us T1 weighted imaging, T2 weighted imaging, and diffusion weighted imaging. It's acute cerebral ischemia within 6 hours. DWI is high accurate in diagnosing acute cerebral ischemia. Acute ischemia in the left frontal and temporal lobes. DWI is superior to conventional MRI. 1.2 Hemorrhagic ischemia. Reperfusion may lead secondary to hemorrhage after 48 hours, showing mixed density on CT or mixed intensity on MRI. The left temporal lobe shows mixed density on CT. 2. Tumor. 2.1 Pilocytic anthracytoma. This tumor is common in pediatric patients. The well-bounded mass, often in worming, showing hyperintensity on T1 weighted imaging and hyperintensity on T2 weighted imaging. The mass has less surrounding edema and enhancing mural nodule. 2.2 Meningioma. Meningioma is the most common actual axial tumor, which women often affected. Meningioma is hyperdense with variable surrounding edema, calcification, and homogeneous enhancement on CT. It has typically isoindents to gray matter on T1 weighted imaging and T2 weighted imaging, and duratile of enhancement. Can you see the tumor? The tumor is in right or left area. Can you see the tumor? The meningioma is in the right frontal area. It shows typical isointense to gray matter on T1 and T2 weighted imaging. The mass is in the right frontal area with duratile on contrast MRI. The meningioma is outside the brain, called actual axial mass. The meningioma is in the right frontal with edema and calcification as intense to gray matter on T1 and T2 weighted imaging. 2.3 Hemangioma. New MR by NewSoft give us precise and incarnative imaging, providing incarnative images with multiple contrast by brain count only consumes 6 minutes. The mass has mixed intensity on T1 and T2 weighted imaging, showing hyperintensity on SWI. The mass near the posterior wall of the right lateral ventricle is diagnosed as hemangioma. Glioma. The left temporal lobe has a mass with hypointensity on T1 weighted imaging and hyperintensity on T2 weighted imaging without hemorrhagic signal intensity. Brain count can give us SWI and QSM displaying hypointensity. So the hemorrhagic in glioma is diagnosed. What I'm going to talk about part 2 is the bone tumor. Osteochondroma. Osteochondroma arise from the context and growth outside, pointing away from the nearest joint. The conical and cancellous bone of the lesion is connected with that of the bone from which it arises. Giant cell tumor. Giant cell tumor is an expansive, destructive lesion, usually found in the end of long bones. Most common locations are the distal femur, distal radius, and proximal tibia. The lesion expands to the subarticular bone or joint surface but doesn't involve the joint. The lesion is eccentric with sharp jaw without sclerotic. If the patient had cancer history, who found ache on bone with destructions, metastases should be taken into account. Primary tumor of bone are uncommon, whereas bone metastasis is encountered daily. What I'm going to talk about part 3 is the liver benign disease. Hepatic cyst. Hepatic cyst is well defined and water-like on CT. Cyst displays very low signal on T1 weighted imaging and high signal on T2 weighted imaging without enhancement. The century of absence has no enhancement. It has ring enhancement and interceptor in wall called honeycomb sign. It also has surrounding low-density edema called halo. The abscess is ill-defined with low signal on T1 weighted imaging and high signal on T2 weighted imaging. The century signal decreases on T1 weighted imaging and increases on T2 weighted imaging, with a higher signal outer margin on T2 weighted imaging. The wall of abscess displays delay enhancement, halo, and central enhancement. 3.3 Cirrhosis. Cirrhosis is the endpoint of a wide variety of chronic disease processes. CT and MRI could show hepatic atrophy, nodule surface, disproportionality of hepatic lobes, and gastric varices. 3.4 Hemangioma. Hemangioma, sometimes with hypodensity on CT, reveals T1 weighted hypointensity and T2 weighted imaging markedly hyperintense. Artery phase shows ring nodule enhancement. Portal phase shows contrast enhancement, progresses centripetally. Let's look at some cases. Medical imaging has a greater impact on the diagnosis of disease of the central nervous system. Plain film was widely used in neurological practice. Now CT and MRI has become the diagnosis modality of choice for evaluation of neurological disease. What's the difference between CT and MRI? CT is sensitive in the evaluation of bone tumor. The advantage over conventional radiography is its ability to provide 3D imaging, good contrast resolution, and accurate measurement. The use of reformation can provide better imaging display. MRI plays a leading role in the evaluation of bone tumor. MRI is the only imaging modality that can show hemorrhage, edema, and soft tissue mass. What abnormality can you find on DR and CT? Cellular enlargement. Can you find the cellular enlargement? The patient had pituitary Rask cyst containing high signal intensity. The hyperintensity may be hemorrhage. How can you analyze the abnormalities on brain CT or MRI? We should find the mass effect. Displacement of normal structures away from the abnormalities. In a sense of an object-occupied space, the normal midline structure may be shifted, controlled laterally to the mice. Ipsilateral ventricular structures may be compressed. How to look hand CT. Normal hand CT without abnormal density and without midline displayed. Left imaging is normal hand CT. The midline of the brain should be in the middle of the hand and the two sides of the brain should look alike. Any shift of midline structures is presumed to present a mass lesion on the side from which the midline is displayed, called mass effect. Is a 90-year-old man with limited ability of limb for 30 hours. Brain CT was scanned. Patchy low density of the lesion in left and right basal ganglia. Also CT showed brain atrophy with deep ventricular. The same patient's brain MRI was scanned. The lesion in the right lateral ventricular showed high signal intensity on T2 weighted imaging. DWI shows the lesion hyperintensity. MRI displayed the right middle cerebral artery stenosis. Another case is acute ischemic stroke. A 92-year-old man who was weak and unable to work 6 hours ago. Brain CT was scanned. Pantry low density of the lesion in right cerebellar hemisphere. The same patient's brain MRI was scanned. The lesion in the right cerebellar hemisphere showed high signal intensity on T2 weighted imaging. DWI shows the lesion hyperintensity. MRI displayed the right vertebral artery stenosis. Case 3. A 57-year-old man who was weak and unable to work. Difficulty in reading and writing 6 hours ago. Brain CT was scanned. The left lentifold nucleus edema sign was shown on CT. The left lentifold nucleus was hypodensity and its boundary is fuzzy. 7 days later, the lesion changed clearly with markedly low density. Keys for stroke. CT is the first choice in acute stroke in order to exclude hemorrhage and underlying mass. DWI is most sensitive for diagnosis of acute stroke. Ischemic stroke usually have 4 stages. If time less than 6 hours, called superacute stage, 40% of CT and MRI showed normal imaging. However, DWI shows high signal intensity lesions. From 6 to 72 hours, in acute stage, CT shows low intensity, mass effect, wedge-shaped, special signal for MCA, ischemic stroke containing insular rainbow sign, lentifold nuclear edema sign, hyperdensity, MCA. From 4 to 10 days in subacute stage, zero contrast enhancement due to green-white matter edema. If time more than 11 days in chronic stage, CT and MRI could show focal tissue loss. such as atrophy, cavitation, focal ventricular dilatation. Let's look at case 4, hemorrhagic stroke. The patient's brain MRI was scanned. The lesion in the left basal ganglia showed high signal intensity on T1 weighted imaging and T2 weighted imaging. DWI showed the lesion hyperintensity. MRI displayed the left middle cerebral artery's obstruction. Is hemorrhage stroke. Case 5. A 56-year-old woman who was dizzy for 1 week. Brain CT showed hyperdensity on midline. The lesion had calcification without surrounding edema. It has typical S-intensity 2 green matter on T1 and T2 weighted imaging. The lesion had homogeneous enhancement, Duretil sign. In contrast, MRI. The mass was an actual axial tumor. Which brain tumor is the most common actual axial tumor? Meningioma is, and women are often affected. Case 6. Meningioma. Brain CT shows hyperdensity on frontal area. The middle line shift. The ventricles was compressed. The lesion didn't have calcification, but with surrounding edema. It has typical S-intense 2 green matter on T1 weighted imaging. In contrast, MRI, the lesion had homogeneous enhancement and Duretil sign. The mass was meningioma in man. Case for meningioma. Meningioma is hyperdense with variable surrounding edema, calcification, and homogeneous enhancement on CT. It has typical S-intense 2 green matter on T1 and T2 weighted imaging and Duretil of enhancement. Case 7. Is the patient with meningioma? The mass had no calcification and surrounding edema. It had initial intensity 2 green matter on T1 and T2 weighted imaging. In contrast, MRI, the lesion didn't have homogeneous enhancement like half-ring enhancement. The mass was an actual axial lesion. The pathology was inflammatory pseudotumor. It was difficult to identify from meningioma. Case 8. Parasitic antrocytoma. This tumor is pediatric patient. The location is Burming showing hyperintensity on T1 in imaging and hyperintensity on T2 weighted imaging. The mass had less T1 and hyperintensity on T2 weighted imaging. The mass has less surrounding edema and enhancing mural nodule. So the most common pediatric brain tumor like these MRI findings is parasitic antrocytomas. Keys for parasitic antrocytomas. The most common pediatric CNS tumor arising in the posterior fossa. About 66% are cyst-like with an enhancement mural nodule, warming hemisphere mass. They are iso or hyperintensity on T1 weighted imaging and hyperintensity on T2 weighted imaging. Surrounding edema is rare. The mural nodule of the cystic form enhancement intensely, while the short-lived component of the non-cystic form enhancement moderately. Case 8. Osteochondroma. It's a man with 37 years old who had ache in his leg. The tumor arises from the context and grows outside, pointing away from the nearest right key joint. The conical and cancellous bone of the lesion is connected and has the same signal with that of the bone from which it arises. Keys for osteochondroma. The tumor arises from the context and grows outside. Second, pointing away from the nearest joint. 3. The cortical and cancellous bone of the lesion is connected with its mother's bone. 4. Most common locations are the femur and tibia. Summary. Today we share three systemic disease in nervous system containing two common diseases. 1. Acute ischemic stroke. CT is the first choice in acute stroke in order to exclude hemorrhagic and lying mass or AVMs. We can see the special signs for MCA ischemia, containing insular rainbow sign, lentiform nuclear edema sign, hyperdensity MCA. And 2. Meningioma. Meningioma is hyperdense with variable surrounding edema, calcification, and homogeneous enhancement on CT. It has typical as intense 2-green matter on T1 and T2 weighted imaging, and duration of enhancement. In skeletal system containing two common diseases, osteochondroma, the tumor arises from the context and grows outside, pointing away from the nearest joint. Giant cell tumor is expansive destructive lesion with a sharp jaw without sclerotic rim. In digestive system containing two common diseases, hepatic cyst. Hepatic cyst is well defined and water-like without enhancement. The hepatic abscess is well defined and the wall of the abscess displays delayed enhancement. Halo and control have no enhancement. I'm be happy to tell you about my experience on imaging diagnosis of common disease. That is all. Thanks for your attention.